All right, so this is the first of two lectures for Chapter 42 in your book, the Diabetes chapter of Unit 6, Systemic Disorders. And in these two lectures, we're going to cover the biochemical aspects of diabetes, which is very prevalent in the United States. It's a huge public health problem in the US due to its many complications. So in this first lecture, we're going to give an overview of diabetes and then dive in deep on diabetes type 1 specifically, and then also cover the concepts relevant to hypoglycemia as well. So specifically, we're talking about diabetes mellitus, not diabetes insipidus, which primarily affects the pituitary gland. So diabetes mellitus is a group of diseases that have chronically high levels of blood glucose. Now, anyone, even your healthy 20-year-old marathon runner will have a spike in glucose. They eat a piece of cake or drink a soda or, a high carbohydrate meal, and their blood sugar levels will go higher than normal. However, those get corrected in a healthy individual. Diabetes occurs when you have prolonged periods of high levels of blood glucose. And there's two main types. There's type 1 and type 2. Type 1 is typically more congenital, meaning that you see it diagnosed frequently in younger individuals, such as children or adolescents or young adults. And this is where really the pancreas fails. So you have the beta cells in the pancreas. And they secrete insulin. So they synthesize it and secrete it in response to elevated glucose. So you have elevated glucose, it stimulates the beta cells to secrete insulin. Now, in people with type 1, they don't produce enough insulin. And so as a result of that, they're not able to benefit from the long-term or downstream effects of insulin, because what insulin then ends up doing is that it binds to the insulin receptor, which is essentially, a cellular surface receptor. So you have insulin here binding to the receptor like this. And that receptor has all these downstream effects. Now, the main ones of that are they stimulate the insertion of GLUT transporters, mainly GLUT4. And the GLUT transporters are responsible for taking glucose out of the bloodstream and bringing it into the cell. So the issue in diabetes, no matter if it's type 1 or type 2, is they both have high levels of glucose, is they're not getting glucose into the cells. They just can't do it. Either in type 1, you don't make enough insulin to stimulate the uptake of glucose. And then in type 2, which is more, you see more in older adults, which is more of a result of often lifestyle, and then obviously genetics also plays a significant role as well. But you see it where their insulin receptor becomes resistant to insulin. So you have enough insulin, but then the issue is that this interaction between insulin and the insulin receptor, because there's resistance that develops. And you see that in type 2. So this also results in a lack of glucose uptake into cells. So either way, either the receptor isn't able to efficiently bind or is resistant to insulin binding and you can't get glucose in, or you just don't have enough insulin. Now, what ends up happening, and we'll talk about this in type 2, is they only have normal levels of insulin for a certain amount of time. What happens over time, though, is in response to that, the beta cells keep increasing and increasing output of insulin, and then eventually they tire out or they blow out because they only have a certain threshold. It's like an engine in a car that's just pushed too hard, or an engine in a factory or something that's just pushed too hard. Eventually it breaks, and then eventually these patients, unfortunately, also don't have enough insulin in addition to having insulin resistance. But we'll get more into that later in the lecture. You can also have diabetes caused by excessive secretion of growth hormone, or GH, also epinephrine, and in patients taking steroids over a long period of time, or glucocorticoids. So the initial symptoms, typically either if you have type 1 or type 2, are polyuria. So this is excessive urination. So what happens is like we said, you have chronic levels of high levels of glucose in the blood. And what happens is they get, filtered in the kidney. So you have the kidney here, which are these, bean-shaped organs in the abdomen, and they're filled with these structures called nephrons that filter the blood and then also produce urine. So blood comes in through these blood vessels in the renal corpuscle here, and then the fluid gets filtered, and then the blood ends up returning back to the bloodstream. And then here you have the first filtrate, is what it's called, and then it goes through the whole nephron here, and then it gets into the collecting duct, and then it becomes the urine, which then goes to the bladder and then is peed out. So in the proximal convoluted tubule, you have these glucose transporters. Okay. And so they take glucose out of the filtrate and reabsorb it, because you want to reabsorb glucose. Otherwise, you're just wasting it. If you eat a bunch of glucose and then you just pee it all out, what's the point? So you want to reabsorb it. And usually in the urine, there's very tiny amounts of glucose, if any. And so because the nephron is doing its job and it's reabsorbing the glucose. Now, what happens in the patients with diabetes is that they have such a high level of glucose in the blood that it ends up spilling over. And what happens is that you have too much glucose. You just have way too much glucose. It not only is high in the blood, it spills over here into the filtrate, and you have a high level of glucose here in the nephron. And so these transporters have what's called a Tmax, or a saturation point, if you will. And so let's just say it's an arbitrary number of 100. So it can handle 100 glucose molecules. Okay, so if you have 100 or less glucose molecules, no problem. You're going to get them reabsorbed back into the bloodstream. Let's say you have 200 though. If you have 200 glucose molecules, you're going to get rid of 100 of those, but then you're going to have another 100 left over that shouldn't have been there. Remember, after this point, it's usually a very small amount, if any. But now you're going to have 100, in our theoretical example here, you have 100 extra glucose molecules. So you have glucose coming down all through the nephron here. And so what happens is you have all this extra solute. Now, if you remember osmosis, the classic is this kind of U-shaped tube, and then you have a semi-permeable membrane in here. If you have a high amount of solutes on one side and then a couple solutes on one side, eventually what water is going to do is it's going to go to the side of the higher solute. So what happens is all this glucose in here kind of acts as an osmotic force, and so it pulls water into the nephron, and then eventually it increases the volume of the urine. And so you're increasing the amount of glucose excreted, and then because you're pulling in all this fluid and then sodium, that gets sent down to the urine. So you have a higher volume of urine produced, and so the bladder just keeps getting refilled, and you end up having to pee a lot more. And so that's what ends up happening. And since you're losing more fluid to the urine, your blood volume actually decreases, and we'll talk about that in a second, how that can cause problems. And so the other symptoms that patients will have is polydipsia, which is where they're thirsty all the time. So they have an excessive feeling of thirst, and that's because if you have excessive urination, like I said, you're going to have decreased effective circulating volume, or low blood volume. So your body responds to that by saying, oh, hey, I need to drink more water to replenish that. And so you feel thirsty because you're peeing all the time. So these patients, they're going to be peeing a lot, feeling very thirsty all the time. They also develop what's called polyphagia, where they feel the increased desire to eat a lot. And that's because even though they have high levels of glucose, they're not using that glucose. They actually have decreased glucose utilization. It's kind of counterintuitive. They have these unbelievable amounts of glucose in their bloodstream, but it's just not getting into the cells to be used. And so what happens is the body thinks it needs more glucose because it's not using it. You could also think of it as the body thinks it's in the fasting state. Because for all intents and purposes, it essentially is in the fasting state because you're not using glucose. You need to find other sources of energy. If you can't use glucose, you need to find something else to use. And so that's where the body begins using other methods, but then also is telling your brain that you need to eat more. You need to get and consume more carbohydrates or glucose. Then what you also see is sudden weight loss, because if you're peeing out all this fluid, you're going to cause an acute weight loss as a result of that. Now, each type of diabetes has its own serious condition that develops either from no treatment, so it's often the initial presentation. The patient ends up, they're living with this and they end up developing diabetes, and then they don't know it yet, and then eventually it progresses to the point where they develop one of these conditions, depending on which type they have. This also happens, unfortunately, if patients are non-compliant with their medications, meaning simply they don't take their medications, or they're unable to gain access to their medications for a variety of socioeconomic reasons. Regardless, they don't have the treatment, and then they end up, unfortunately, going back into one of these states. And so for type 1, it's diabetic ketoacidosis, or DKA, or type 2, hyperosmolar hyperglycemia non-ketotic syndrome, or HHNS. And the USMLE loves to ask about these. They're very high yield. They're also very high yield for medical school and graduate school exams as well. So for diagnosing diabetes, we're not going to dive too far deep into this. This is more, something you'll get into in your clinical rotations. But what you'll see is that serum hemoglobin A1C, or your A1C, or HA1C as people will call it, is the main diagnostic tool, especially clinically is the A1C. Someone comes in, it's almost part of the standard workup, or if, someone goes to a primary care doctor and they're a new patient, it's part of that. Or if you definitely have suspicion for diabetes, you would definitely measure an A1C in a patient in the hospital. The reason for that is because what happens is that hemoglobin becomes bound to glucose via a process called glycosylation. So you've got hemoglobin traveling in the body, and obviously it carries oxygen. What you have over time is actually glycosylation of hemoglobin, which is where you have essentially glucose forms a bond with it. This is non-enzymatic, so there's no enzyme catalyzing this. This just happens over time. You get the concentration of glucose becomes high enough that it ends up glycosylating or becoming bound to hemoglobin. There's a certain basal level or small level in any individual, but the problem is if someone has chronically high levels of glucose, obviously they're going to have much more hemoglobin that undergoes glycosylation. And that's why this is a great test, because it's something that measures it over long periods of time. It actually reflects the average blood glucose level over the last 3 months. Because remember, anyone can have a spike in glucose, but not everybody has a long-term chronically elevated level of blood glucose. And so that's why this is a great test. And the reason for that is because the RBC lifespan is about 120 days or 4 months. And so if you measure it, it's usually going to reflect it over the past 3 months. And the value you want to pay attention to is 6.5. If it's at 6.5 or higher, that is diagnostic for diabetes. A couple other tests that can be used, but they're not as commonly used, just mainly for practical reasons. A1C, you can just take it. Someone doesn't need to be fasting or anything like that. It doesn't need any follow-up. You take the test the one time and that's it. Versus you have a fasting plasma glucose level. So you measure the blood glucose level using a finger prick test. And this is after a significant period of fasting. So you have the patient not eat anything for 8 hours or more, and then you measure the blood glucose levels. Now remember, if someone's fasting, if you have a 20-year-old marathon runner who's healthy, they're not going to have high levels of blood glucose. They're going to have taken it all up and used it. They're still in need of energy. They're going to, as we talked about in the metabolism unit, switching to other sources of energy or undergoing gluconeogenesis. And so someone who with diabetes, they're going to still, even after fasting for 8 hours or more, they're going to still have really high levels of glucose because in that time, they still haven't cleared it. They haven't taken it up into the cells. So if that blood glucose level is at 126 or higher milligrams per deciliter, that indicates the patient has diabetes. The other thing you can do is the 2-hour oral glucose tolerance test. So you give oral glucose, then you take a blood sample about 2 hours after they've taken that oral glucose, and this determines how well the body clears that glucose from the blood. Now, if the blood glucose level in these patients is at 200 or higher, that's indicative of diabetes. So you can see why the A1C is more commonly used to diagnose diabetes, because the fasting glucose level and the 2-hour oral glucose tolerance tests, they require a patient to fast, take oral glucose, and they're just not convenient. Certainly not as convenient as an A1C, which is just a simple serum lab test. Plus, the A1C gives you a better picture of the patient's health over the past few months, versus these other tests are just measuring glucose levels at one point in time. Treatment-wise, we'll get into this more, but mainly in type 2, because that tends to be more of due to lifestyle. There is obviously a genetic component, but it's very common in patients who are morbidly obese or obese. And so one initial treatment strategy may be that the patient just changes their lifestyle, maybe goes on a low carbohydrate diet, exercises more, tries to lose weight, and often that can be effective and actually bring someone's chronic high blood sugar down and actually help control the patient's diabetes. Now, depending on how bad it is, you may have to just give medications right out of the gate, or if this doesn't work, then you got to give medications on top of doing this. You're always, everyone, should, especially diabetes patients, should be always doing this. Whether you need medications or not, that's, up to the physician and essentially how bad it is. The thing with type 1s is since they don't have insulin, oftentimes you can't just do this. You got to give some type of exogenous insulin to replace that. And so oftentimes those patients have to go on insulin therapy. The other thing is managing the complications, which we'll talk about. That's another big part of managing diabetes, not only treating the primary disease itself, but also the complications of that disease as well. Now, speaking of some of those long-term complications, they again, like the A1C test, involve non-enzymatic glycolation of other structures, such as small and large blood vessels. And so as a result, this leads to worsening of atherosclerosis, so hardening of arteries, narrowing of arteries. It worsens coronary artery disease because it worsens atherosclerosis that's occurring within the coronary arteries. Peripheral artery disease, particularly when you have someone's extremities like this. If you have the blood vessels like this, and you have narrowing of the vessel, the blood flow to the distal leg is much, much decreased. So it's similar to like when you have, angina with a heart, or even a myocardial infarction due to decreased perfusion of heart tissue. When you have narrowing in these major blood vessels in the legs, they decrease perfusion to the distal leg, and this tissue can end up, diabetics are at risk for getting ulcers. So they get really bad ulcers because their tissue just doesn't heal as well. It doesn't get good blood flow. And unfortunately, if they develop chronic ulcers and they don't get treated, it's a huge risk factor for developing gangrene of the foot or lower extremity, and then they end up having to undergo amputation. Diabetes is actually a major cause of amputations to occur in the United States because of peripheral artery disease that develops in diabetics. So it's a huge problem. And it all comes back to non-enzymatic glycolation of small and large blood vessels. So you've got these endothelial cells in these blood vessels, and you get binding of glucose, which if you already have plaque there, that just further complicates things. You also have retinopathy. We'll talk about that in a second, how that develops. You have neuropathy, where the nerves, so a lot of diabetics, they get numbness in their distal extremities, so in their feet and in their lower legs, and then often in their hands as well, because the nerves get affected. And then nephropathy, so they're at very high risks of kidney complications. The number one cause of patients having to go on dialysis for kidney failure in the US is actually due to diabetes. So as you can see, some pretty significant complications that can occur from diabetes, especially if it's not treated well. So a big cause of a lot of these is osmotic-driven accumulation of sorbitol, which leads to damage of several tissues. So how that happens exactly is, so you have one pathway for glucose to be metabolized. It can be converted into this other molecule called sorbitol. And the enzyme that catalyzes that is aldose reductase. So this pathway in a healthy individual is not typically used. It's used at a much lower rate. However, if you have really high levels of glucose, so instead of undergoing the typical metabolic pathways, glycolysis, and so forth, a lot of this glucose, since you have such an overload of it, actually gets shunted to this pathway. So this pathway actually has increased activity in diabetics. And why do we care? So this enzyme is located in high concentrations in certain tissues. So if you have a cell like this, and glucose gets shunted towards this pathway within that cell, you're going to have much higher concentrations of sorbitol than you usually do. Now, again, why does that matter? Well, sorbitol actually is a significant osmotic driver, so it's going to cause significant accumulation of water. So if you have increased sorbitol, you're going to have increased water or osmotic diffusion into the cell, and you're going to have swelling of the cell. And so as a result of that, having this huge flux of water into the tissue, that ends up damaging it. Because when you have swollen tissues over long periods of time, because you keep producing high levels of sorbitol, that's when you create problems. And so again, as we say here, in healthy individuals, only a small percentage of glucose is metabolized by aldose reductase. In diabetics, however, you get an increased amount. Again, accumulated sorbitol, increased flux of water into these tissues by osmosis, long-term tissue damage. So, like I said, it's located in the following areas of the body. So, eyes, the cornea, the retina, the lens. This is where you get diabetic retinopathy, because you have, if you have your eye like this, is a very simple drawing of the eye like this. This is your lens. And then, your retina is usually in the back of the eye. So, if you have all this water accumulating into the retina and essentially swelling the retina like this, that's going to cause problems. You're not going to be able to see as well. If you have more water in here where you have light traveling through to reach the retina, there's more water for it to travel through, or more fluid for it to reach, for light to reach the retina so you can see, it's going to cause problems. Also, the lens of the eye is swollen as well, so you can get cataracts. So you swell in there as well because you have an increased amount of sorbitol. So diabetes can really have a significant effect on the eyes and vision, and now often and unfortunately can lead to blindness too. The Schwann cells of peripheral nerves, so if you have a nerve like this, remember you have these lipid coats on the outside of the nerve called myelin, and these are produced by Schwann cells, we'll just say SC. And so Schwann cells can myelinate nerves, and remember, myelination increases the efficiency of the action potential so that you can carry out nerve impulses. And so what happens is the Schwann cells, they have a high amount of aldose reductase, and so in diabetes they have accumulation of sorbitol, so they swell and become defective. So you don't have as efficient of myelination of nerves. And if you don't have as effective myelination of peripheral nerves, you're not, for example, in your sensory nerves, especially those ones that go all the way out to your hands and feet, they are not going to be as effective. And so you're going to develop what's called peripheral neuropathy. And it's actually what called is a stocking and glove distribution, meaning stocking meaning like down in your feet and your lower legs, and then glove, in your hands, because that's where it's most distally first affected. And then in the kidney, now nephropathy can actually result from a number of causes. So one, you have aldose reductase, so you have increased sorbitol. The other thing is you have glycosylation of the vessels leading into the nephron, and so that can cause decreased blood flow as well into the kidney and cause defective perfusion. And then as a result of that, you actually end up getting proteinuria. So usually you don't have any protein that makes it through that filtration device or filtration apparatus within the nephron, where, as we were showing you on a few slides ago, where blood's filtered within the kidney, usually protein doesn't make its way into the nephron. Usually it's too big to make it through. But if you have breakdown of that filtration barrier, such as it gets significant glycosylation and then swells because of increased sorbitol, that damages it as well. Then it breaks down and it's not as selective, so you have increased protein making its way into the urine. So as part of our discussion of diabetes, I also wanted to just touch on hypoglycemia. Now, hypoglycemia is a very common presenting complaint to the emergency room, or presenting finding to the emergency room. Usually they have other symptoms, and then you find that they have hypoglycemia. Very common in diabetic patients. Often they'll overtake their medicine, like their insulin, and they develop hypoglycemia. It's something you want to be, if you're adjusting a patient's insulin levels in the hospital, you definitely want to be aware of that and being able to recognize hypoglycemia and treat it accordingly. There's actually a saying in the hospital that says, hyperglycemia is better than hypoglycemia. And the reason we say that is, yes, sure, it's not great to have your blood sugar in the 500s or 600s. But that being said, if someone's blood sugar is dangerously low, that can actually kill them faster, because they can develop seizures, they can develop loss of consciousness, they can go into a coma, they can have trouble protecting their airway and become hypoxic. So it actually can kill somebody if not caught relatively quickly and dealt with. So you definitely, as any physician in training, you want to be able to recognize hypoglycemia and know how to treat it. So, as the name implies, it's when blood glucose levels decrease below normal. They result in neurological symptoms that can include cloudiness, lightheadedness, and confusion. At some point or another, you've probably experienced mild symptoms of hypoglycemia, such as if you went a long period of time without eating, you can feel somewhat cloudy, confused, or lightheaded, or even faint and pass out. The reason for these symptoms, why these patients develop these symptoms, is because, as you recall from our Unit 3 from Metabolism Unit, is that the brain depends primarily on glucose. It is the main fuel that the brain uses. If you don't have glucose there, then the brain kind of gets starved for energy, and it uses up its glycogen stores very quickly. So once it doesn't have the glucose, it uses up its glycogen stores, then there's not much left. Then you got to move into the ketone bodies. But the problem is if this is an acute drop in blood sugar, then you're going to run into a problem. So as a result, when blood glucose level falls, the brain is definitely one of the first organs affected. So they're going to develop these neurological symptoms. However, if you prolong this hypoglycemia, you can cause significant decline in cognitive function because you're essentially starving the brain, motor control, and then, like I was saying, you can lose consciousness, develop seizures, coma, and even death. And so these are the ones you definitely want to be aware of, losing consciousness, seizures, and then obviously patients can then progress to this. So definitely want to be aware of that. Typically, it occurs in diabetic patients. They either take too much insulin or too much sulfonylureas, which is another diabetes medication. It can also, like I was saying, occur in healthy individuals that fast too long. It often can happen also in patients that are in the hospital, where either they have dementia or something and they don't eat, or they need help with eating and they just haven't eaten for a while. Also, if patients often the night before procedures, they're instructed not to eat anything after midnight so that they have a decreased risk of aspiration with anesthesia. The problem is that if the procedure's not till later in the day or the end of the day, patient goes all day without eating anything, and you see where this is going, they can develop hypoglycemia that way. So it's a very common problem seen in the hospital and in the emergency room. Other causes include hypothyroidism, so thyroid hormone stimulates metabolism. You can see it in kidney failure, liver disease. There's certain drugs that can cause hypoglycemia, including alcohol, so definitely want to be aware of that. The treatment, I mean, the way you diagnose it is you just finger prick test and you look at the blood sugar level that way. You just do point of care glucose level and see what the serum glucose level is. The goal is to raise the blood glucose level and at a rate that depends on the degree of the symptoms. So if a patient's having mild symptoms where they're kind of confused or cloudy, honestly, you just give them some snacks. Give them some high carbohydrate, give them some orange juice, give them some crackers, bread, something rich with carbs to help bring their glucose level up very quickly. If they have very severe symptoms, then you actually give them IV dextrose, which is essentially sugar water. And then you just connect it to an IV and infuse it directly into their bloodstream. So that's what you would give in scenarios where more severe symptoms. As far as diabetes type 1, so this is, like we were saying, is an autoimmune disease, autoimmune destruction of the beta cells of the pancreas, which are the cells that make insulin. It's carried out by antibodies against glutamic acid decarboxylase and cell-mediated immune responses. This pathology or this process is still being further studied, so the exact mechanism of how this all happens isn't quite fully elucidated yet, but you definitely want to be aware of antibodies against this enzyme. You also, this is a common test question. Again, this isn't necessarily well known either. It's still being studied. Is that these patients typically have human leukocyte antigen or HLA genes, HLA-DR3 and DLR4. For some reason, those get asked a lot, especially in the USMLE. Human leukocyte antigen is essentially these cell surface receptors that help mediate immune responses. And so they've done genetic studies on diabetes type 1 patients, and they've found that they have high levels of expression of these particular genes. And so that's commonly seen. It can be part of the diagnostic workup, but obviously once you get to that point, they've probably already presented with other symptoms. Typical patient, like I've said, is a younger patient, less than 30 years old. You can see it in older patients, but it's going to present earlier in life. And they present often with classic acute symptoms, like we were saying, polyuria, polydipsia, polyphagia, sudden weight loss. They also, unfortunately, often present with diabetic ketoacidosis, or DKA. So DKA is a life-threatening emergency. Very commonly, we'll see this presenting to the emergency room, and often it can result from either a lack of treatment. So either these patients, haven't been diagnosed, they're kind of a new case of diabetes type 1, and either they don't know it yet, or they haven't followed with a primary care doctor in a long time. Unfortunately, also it can happen when patients are diagnosed with diabetes type 1 and they're not compliant with their medications. The other thing is, the patient can be developing type 1 diabetes, or even being treated with it, and there can be additional stresses to the body that require even more insulin, such as infection. So, a patient can develop an infection, and that can trigger them to go into diabetic ketoacidosis. So the causes can be sometimes complex. They can involve, again, lack of insulin is always the issue, but then also you can have things like infection as well that can trigger it. Now, the biochemistry behind this, I thought this diagram here that we used a lot in Unit 3, the metabolism unit, to kind of explain the interplay between all these different pathways, I think would be helpful here to explain what's going on in diabetic ketoacidosis. Now, again, the major issue, obviously, is you have decrease of insulin. And then as we show in the diagram here, you have increased glucose. Now, remember, in Unit 3, we went over kind of fasting and then starvation. The body thinks it's in the starvation state. Even though these patients, they can have blood sugars, 300s, 400s, 500s. I've even seen it into the 600s. You can even see it go higher than that. This is not uncommon to see this at all. And so what happens is, even though you have these crazy high levels of sugar in your blood, it's just not getting in because you don't have the insulin. And so if you don't have the insulin, your body, and you're not using glucose, your body thinks it's in the starvation state. So what happens? You're going to have increased glucagon, increased epinephrine, because you're stressing the body, you're in a starving state. So what happens is you actually see decreased glucose utilization. So you're going to see an uptick in gluconeogenesis because the body thinks it doesn't have any, so it's got to make it. And so you see mobilization of these other energy stores. So you'll see breakdown of triglycerides into fatty acids. Then you see beta oxidation of fatty acids to create acetyl-CoA. So you see a significant buildup of acetyl-CoA. You can see breakdown of proteins into amino acids and so on. The big thing though is eventually you're all going to lead back to increasing acetyl-CoA. And then what happens is acetyl-CoA gets used to make ketone bodies because you're in a starving state. And it all comes back to, remember, the brain primarily uses glucose. It can also use ketone bodies. So it's making ketone bodies to then help fuel the brain. Now, ketone bodies are actually acidic. And so essentially, hence the name, ketoacidosis. So when you have increased ketone bodies, you have increased acid. And so that's going to drop your pH. So that's the other thing is, these patients are going to come in, they're going to be crazy high levels of blood glucose, low pH. And so those are going to be kind of the hallmark signs. Again, it all comes back to you don't have insulin, you can't use glucose, your body thinks it's starving, so then it's going to have to mobilize other stores of energy. Clinical features, again, just like when we were talking about hypoglycemia, essentially the brain is not using glucose. So you're going to have like these neuropsychiatric symptoms. Delirium, psychosis, even. Oftentimes these patients can come in, they're totally unconscious, or they can't even answer questions or participate in giving you any kind of history or anything. You can see Kussmaul respirations, which are characterized by rapid and deep breathing. Very often they have pretty severe abdominal pain. They can have nausea, vomiting. As a result of that, they get dehydration. They can actually have a fruity breath odor. This is very commonly described on question stems, and that's due to exhaling acetone, which is actually one of the ketone bodies. So acetone is one of the ketone bodies, and it's responsible for this odor. Now, I was kind of talking about the labs earlier, but again, just to kind of put it all in one place, hyperglycemia, you see acid blood pH, and then you see increased levels of serum ketone bodies. So when these patients come in, they're delirious, they've got severe abdominal pain, they're nauseous, they're throwing up, you're going to get a blood glucose level, you're going to get a pH, you're going to look at the level of serum ketone bodies. You're also going to get a lactic acid as well. And so you're going to see lactic acidosis. You could even see leukocytosis and elevation in white blood cells because it's kind of a pro-inflammatory state as well. You can see hyperkalemia or elevated potassium in the blood, and then hypertriglyceridemia. So the hyperkalemia is actually kind of interesting and fairly complex. So let's actually draw a little bit of a cell diagram down here. So if you remember, you have the sodium-potassium pump, which is moving sodium out this way against the concentration gradient, and then it's moving potassium into the cell, and then it uses ATP. Now what's interesting is insulin actually stimulates the sodium-potassium pump. And in fact, in patients that does not have DKA, if they have hyperkalemia, let's say it's a patient you're following in the hospital for something else like heart failure or something else that's not DKA, and they develop hyperkalemia, one of the first lines of treatment you can give is insulin, because you can just stimulate movement of potassium from the bloodstream into the cells. Now, in those cases, you actually give them dextrose as well so that they don't develop hypoglycemia. Now, back to patients with DKA. They don't have insulin, so they're going to have low levels of insulin. They're not going to have as much stimulation of the sodium-potassium pump, so that's one cause of them having high levels of potassium, because they're not moving as much potassium into the cell via the sodium-potassium pump. The other exchanger that you want to be aware of is the hydrogen-potassium exchanger. So that moves hydrogen into the cell and then moves potassium actually out of the cell. Now, remember, this is an acidosis. It's a ketoacidosis. So you're seeing high levels of potassium. So that's going to drive this transporter to move hydrogen into the cell to kind of essentially a way the body that compensates for this acidosis. And then as a result of that, it's going to move potassium out. So your intracellular potassium in a patient that's initially presenting to the emergency room with DKA, their intracellular potassium store is going to be really low. Remember, potassium is higher intracellularly than it is the concentration of potassium inside the cell in a normal individual is actually higher than potassium outside the cell. Now, in someone with DKA, this is going to be significantly decreased. As far as hypertriglyceridemia, again, they have decreased insulin, so then they have increased fatty acid esterification in the liver, decreased lipoprotein lipase activity in adipose tissue. So remember, this is a enzyme that breaks down triglycerides so that they can then be used as fatty acids. And instead, since you're not breaking them down, you're actually going to increase the store of them. So you have increased chylomicrons, increased VLDL, so you have increased triglycerides because, again, you're not breaking them down via lipoprotein lipase. You're also increasing esterification, which is where you're combining fatty acids with glycerol, because remember, glycerol gets bound to, is that sugar molecule that gets bound to all of 3 fatty acids. So you're having increase of that, decreased breakdown of this. So again, you're going to have to store them in chylomicrons and VLDL. So they have high triglycerides as well. The way you treat them is you definitely give IV fluids. A lot of times these patients are throwing up, so they're dehydrated. They're oftentimes malnourished. You're definitely going to give IV insulin. Give a lot of IV insulin because they just don't have insulin. You want to bring the sugar level down. The other thing is that you want to help bring the potassium level down because high potassium can actually cause heart arrhythmias, which can kill a patient pretty fast. Oftentimes you'll give insulin mainly obviously to bring the blood sugar level down and replete insulin, but the other reason you give it is to stimulate driving of potassium into cells. Now, a key thing here is you're not decreasing total body potassium. You're just moving it from one place to another. You're moving it from the bloodstream into the cells. So your body still has the same amount of potassium, but it's just you've moved it from the bloodstream where it can potentially cause arrhythmias with the heart to inside the cells so that the patient no longer has potentially harmful levels of high potassium in the bloodstream. So actually, after you have treated patients, sometimes their potassium level can be normal or even decreased. So you got to be careful of that. So sometimes you actually got to watch that and actually give potassium to replete that. Also, you got to be careful about bringing the blood sugar down too fast, because then they could even develop hypoglycemia. So in those cases, you may even give some glucose. It's not the first line of treatment. Definitely not. You want to check the blood glucose levels regularly, and then you want to make adjustments. These patients are very often admitted to the intensive care unit or the ICU because they, as you can see, they need a serious level of treatment with all these IV fluids, IV insulin. They also need very close monitoring, very frequent lab draws to make sure that these electrolyte levels are balancing out and that their blood sugar is coming back down. As far as when you get them out of DKA, the long-term treatment is you're going to give them insulin therapy. These patients, unfortunately, are just going to have to go on insulin therapy because they're not making it. All right, so that closes out the first diabetes lecture. In the next lecture, we're going to talk about diabetes type 2 and then some pancreatic neuroendocrine tumors.